Good afternoon. Welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks for joining me today. Today is July 7th, 2022 for Facebook Live. And let me tell you our roadmap for today. So first thing we're going to do is have Dr. Eric Riley on, our surgical podiatrist here at CGH. And he's going to talk about all things foot and ankle related with us today. And then once we get done with our conversation with Dr. Riley, I'm going to give you an update on COVID and the pandemic. And I have some little more detail than I have had usually in the past month or so that I wanted to share with you. And then when we're done with that, we have some shout outs that we want to give today. So that's the roadmap. But with no further ado, let's get Dr. Riley on our interview. Hi, Dr. Riley.
Hi, Bill. How are you?
I'm doing well.
Good.
Well, and yourself?
I'm doing great. Thanks.
Good. Glad to have you.
Yeah, glad to be here.
You have a pretty tall bar to follow up. Last time we were here, I had Dr. Song on. We talked about sex, so we're going from sex to feet. We got to make feet sexy, don't we?
Yeah. We'll try.
All right. So are you ready for some questions? And as always, folks who are watching, if you have something that pops to your mind that you want to ask a question about, feel free to send it our way and we'll answer it, or at least try our best to. So here goes first question. I want to talk about surgery related stuff, in particular pain. So can you talk a little bit, Eric, about what you do to both reduce post-operative pain and also reduce after surgery the need for patients to take opioids?
Sure. So this is, we've been doing a lot of different things, and CGH in particular at this point is well equipped to implement multimodal effects of pain control, both in the perioperative setting and postoperative as well. And this caught a lot of press certainly a few years ago when we started looking into narcotic use and trying to reduce our use of narcotics for the health and well-being of our community. And anytime you make changes like that, it certainly is difficult, right? Because you kind of get into habits of things and, oh no, what am I going to do if I can't write my standard prescriptions and whatnot? And I was an early adopter of that in terms of trying to come up with knowing the pathways of pain and discomfort and trying to address each individual one. And since doing that now for, probably the last 5-6 years or so, I'm actually amazed at how little narcotics I have to write, regardless of what operation we're doing. And I attribute that basically to just being able to manage patients' pain more appropriately rather than just throwing a narcotic at it and thinking, oh, it solves all the problems, because we know obviously pain is much more than, has many more pathways rather than just the ones hit by narcotics in particular. So we start first in the office with a good dose of education and realistic expectations of what it's like to have surgery. Dr. Bird, you know this. I think one of the biggest things that hurt us in the pain world was when it became the fifth vital sign and pain and the expectations of pain. And okay, you're going to have an operation. What do you expect your pain to be? And oftentimes patients will say 0. Well, that's just not realistic. And so we have to kind of reset that expectation. You're going to have surgery. You're going to have pain. It's normal. We'll get you through it. So I think the education process up front in the preoperative setting, and then addressing those concerns in the perioperative setting on the day of surgery, in particular with regional anesthesia. And given the fact that I work in the periphery, that being the foot and the ankle, we can get people long-lasting anesthetic and analgesia or pain control effectively from the knee down, upwards of sometimes 2 to 3 days, which will get them over the threshold by which they're going to have most of their pain, regardless of procedure. Yeah. And then, of course, post-op pain management thereafter, giving them appropriate pain medications and scheduling those and addressing the specific needs, and giving them kind of a titrated um, or more specific pain management rather than just giving them a pain pill.
Right. Yeah. Well, that's good to hear. And I'm one of the other reasons I just wanted to mention bring up this question is I think that's a question that patients before they have a surgery want to be asking. Not just you, but anybody else is, are you going to have these nerve blocks for me prior to surgery, and how are you going to handle my pain afterwards? Because I don't think everyone does it the same way, and I
Right.
think that is a niche here that you and your team, anesthesia team, and everyone does really well here. And I just want folks to be aware of that is not every bunion surgery. It's the same probably in terms of the technique in many ways, but it's not the same in terms of how you address their pain.
Yeah, and every patient's really different. So trying to, hone in and understand the needs of that particular patient and what they want postoperatively. We have some patients who just refuse and say, I don't need any pain medication, and they do just fine. And you have others that require a fair amount of different modalities that we have to do in order to make them comfortable. But really understanding the needs of that patient and addressing those. And I can't say enough good things about the anesthesia service here. In terms of their regional ability, not only in the foot and the ankle, and we carry that on, OB, orthopedics, and the like, and it has dramatically reduced our need for admissions and post-op narcotics, and it's all good stuff.
Yeah, so I'm biased. Of course, I'm biased. I work here, but
as am I.
But I think that is something that is a niche that we do really well here.
Right.
In your surgeries, for sure, that's a niche that you do really well. So I wanted to make sure we highlighted that.
Well, in general, just as one more thing to say about that, again, as a service line to the hospital or to the community, ordinarily you would only see that at a tertiary type hospital or a university type setting. We're very, very blessed to be well supported in that light, to be able to have the manpower and then also the competency of the service line in order to allow those the regional blocks. You just don't get. And again, we're not small potatoes, but we are a community-based hospital.
Sure.
So to be able to offer that service again just speaks to CGH.
And I wanted to talk on another area that had to do with about the experience patients are going to have when they have surgery here with you. Can you talk a little bit about what you're doing to coordinate post-operative medical equipment needs and even post-operative therapy needs with our CGH rehab team? Eric, can you kind of talk a little bit about that?
Sure. I'm a little bit biased and always have been towards physical therapy and rehab because I'm married to one. So.
There you go. That makes sense. Yeah, sure. That's
so it has a special place in my heart, But in all seriousness, the sooner we can get patients back on their feet, the better. And we know that. And we have physical therapy in particular. Sometimes you have to really twist patients' arms to get them to go to therapy. They go, I can move on my own, and it's just going to be a total waste of time. And not so recently, but I mean, my post-operative protocols for rehab start on day 0. Or the day of surgery, and it will carry them all the way through, effectively the first year of their post-operative phase, and working directly with the rehab department. And again, it goes back to education. And I used to take an approach where, look, we're going to give you the option of going to physical therapy. And I don't know if it's me getting older or just more rigid, but I don't allow that to be an option anymore. We know it's going to be in the best interest of the patient. And so we basically set that expectation up front that you are going to go to rehab, and this is what that looks like. Recently, we've taken a step further, and again, it's all about expectations and education of the patient. My concern of the patient is from head to toe, not just this site that I'm working on. And you have to take into account the patient and their needs. and anything I can do to optimize them to have a good outcome throughout their postoperative phase is going to be good. So, for example, somebody's going to require an assistive device to be non-weight bearing. Well, not everybody can use crutches. Not everybody can use a knee scooter or what's called a rollabout. They have a thing called an iWalk, which is effectively like a prosthetic limb. Lots of different modalities to stay off of your foot, and then trying to get that person competent in that safely to navigate their own home. I can't do that. I'm not in their home. I don't see them, but our therapists do a great job. So we get them over to rehab preoperatively for a preoperative assessment and evaluation. Try to get them in there a couple of times to make sure that not only do they have the device, we get them working with the device, and then again, setting expectations of what their rehab course looks like postoperatively.
Yeah, great. Good. Now I'm going to kind of transition here to more the medical, like just questions type of stuff here. So
Sure.
First question is, how much foot pain should a person put up with before they seek medical care?
Well, that's a great question. I'm a firm believer in kind of proactivity, right? And I believe that foot pain is not normal, right? We can probably come up with some reasonable explanation as to why your foot hurts. So if you have a one-off type pain or discomfort, probably let it go. But if you have consistent and persistent discomfort and whatever that may be in that patient's world, I think it renders an evaluation.
Okay. Let's talk bunions. What is a bunion? Are they genetic? And when are bunions ripe and in need of surgery?
Well, so what is a bunion? So, going back to are they genetic? I always tell patients, mom, dad, and the good Lord give you your foot type. What you do with that thereafter is in your environment is kind of up to you. And so are they genetic? It's a combination of factors for sure. You get your foot type, as I stated, from mom, dad, and the good Lord. So then how we treat that thereafter would determine in your environment how fast they develop or quote ripen.
Okay.
I can use your terminology there. So a bunion is a deviation of the big toe. So if you're looking at your foot, and on the inside part of your foot is the big toe, otherwise the great toe. Medical jargon, we call that the hallux, but it's a deviation of that where the metatarsals, or the long bones of the foot, ordinarily are reasonably parallel. So if I can get straight here, yep. So they're reasonably parallel. And so what happens is the first metatarsal starts to deviate outwards like this. And when it does that, the toe stays positioned where it stays put. And so you get a bump on the side of the foot. And so what happens is you effectively uncover the joint, and it's a crooked joint. So it's not just a cosmetic problem in particular of crooked toes or anything like that. It's a rather painful problem because you've effectively partially, I'm trying to think of terms, not medical jargon, but
right.
You've partially kind of dislocated the joint. It's like a bent hinge on a door.
Okay.
Over time, that door is going to wear out, and so during that process, it's painful. So it's a painful problem, and not as well as a cosmetic issue. And when do you get those fixed? Again, it goes back to foot pain is not normal, right? We want people to be at their optimum and their baseline level of activity, and when it impedes upon you from doing your daily life to the level of which you're not comfortable with, and I don't define that. It could be I can't wear shoes. Every time I go to church, I put my church shoes on. It hurts, and I want to go to church every Sunday or every day. Well, then it sounds like you need your bunion fixed. So it's a matter of, again, understanding the patient, where their limitations are, and there's no right time or ripe
time to fix it. Okay, good. Thank you. By the way, thank you, Jackie and Carrie and others for your kind comments towards Dr. Riley. I agree with you. All right.
I'm seeing stuff flashing on the screen, but I'm not really paying it. I mean, I'm paying attention, but
yeah, no, I get it. Yeah.
So I didn't see what those were. I mean,
I have the luxury of you're giving me an answer, and I can take a quick look down and read.
So they were positive. That's great.
Good. Yes, they were positive. Yeah, people. Yeah.
Good.
All right. Let's talk about ingrown toenails.
Okay.
What can we do to treat ingrown toenails like at home on our own? And then when is it time to not be treating them at home?
Right. Well, when's it not time to fix, or when's it not time to treat it on your own? I would say that, and I would implore upon you, regardless of what level of control you are metabolically or systemically, if you have some element of disease, and diabetes being probably the biggest, please do not treat yourself at home.
Okay.
As trivial as it may be to try and cut out a toenail in a diabetic, that's a bad choice. It's like a serial killer and a knife. Just not a good choice.
Okay.
So those individuals should not be self-treating. Other folks, again, I get asked this a lot, is as to how to cut your toenails to prevent that of an ingrown toenail.
Yeah.
If you're going to get an ingrown toenail, you're going to get it. Sometimes cutting the corners out at an angle, everybody has their kind of little tricks, but there's no right way to try and prevent an ingrown toenail. Once you get the ingrown toenail, again, I think it does warrant probably an evaluation by somebody, and we're happy to take care of them. In fact, we prefer that because oftentimes it's not that it's treated inappropriately, but a lot of times this doesn't need antibiotics, and we see that antibiotics are given kind of as a first line level of defense. And if you just deal with the mechanical problem by removal of the nail itself, not the whole thing, just the section, then you eradicate the problem, and then you don't require that of antibiotics. Ironically, it's probably one of my favorite procedures to do, and I'd never thought that. I mean, you look at the foot and ankle, and as complex as it is, you do a lot of fun stuff, but there's nothing more gratifying than having a patient come in your office. And I don't know if you've ever had one, Bill, but they're miserable. And every step you take, it's like a toothache. And they come in, you see them, you treat them, and they leave your office, and they're just pain-free, and they're effectively, taken care of.
Yeah.
We can take care of these temporarily to get people out of trouble. And then for folks who have chronic problems with nails, there are permanent solutions as well. And these are in-office procedures.
Yeah. Okay, good. One of the things you were just talking about was the diabetics, and for ingrown nails, it's not a good idea for them to try to take care of those themselves. This kind of flows into my next question. So, one of the complications of diabetes is something called neuropathy. How does this affect the feet, and what kind of complications can arise as a result of that neuropathy, Eric?
Sure. So neuropathy in particular comes in many different flavors, and many different problems can cause neuropathy, but specifically that of diabetes. They start to lose the function of the nerves that control basically the small nerves of the feet, right? And so this is both motor and autonomic. And so the biggest issue is when they start to lose sensation. And again, talking about the various different levels of sensation has different pathways as well. Vibration sense, which people don't really think about, vibration sense, that's the first sensation that you lose in diabetic or peripheral neuropathy. Specifically, we're talking about diabetes here. And then there's another threshold that we really start to get concerned about, and that's folks who lose what's called protective sensation. And we measure that through grams of pressure. And we know that 10 grams of pressure which is basically if you take a small little, it almost looks like a fishing wire,
Mm-hmm.
and you bend that on the skin. And if you can't feel that, then you've lost your ability to protect yourself. And we know that those individuals that are heightened risk to getting into trouble, and they may or may not feel that they have and we've seen all kinds of stuff, rolled up socks causing blisters, which then leads to ulcers, which gets infected, and then it leads to loss of part of the foot, limb, or even life. We've seen cat toys in shoes where people don't know they're there, and you look at
Wow.
the bottom of the foot and it looks kind of like a goofy ulcer, and you're like, wonder what's in the shoe. Oh, there's a cat toy.
Mm.
So really neuropathy, and then more importantly, blood supply. If you couple those two things together and you have neuropathy coupled with a decreased level of blood flow, there is nothing more risky. And it's ironic, but the data shows there's nothing more risky on a 5-year mortality rate other than pancreatic cancer, believe it or not.
Wow. Okay.
So it is paramount that these folks are not only evaluated, seen, risk stratified, and then appropriately try to prophylactically manage those people if they
Yeah.
stay with you and follow up.
Yeah. So like, if you know you have it, these are the folks that you definitely want to get in diabetic shoes and those type of things. Always wear shoes. That's kind of what we're going for here.
Yeah, absolutely. Evaluate them. Again, we manage these folks. We stratify them on how often we're going to see them. Unfortunately, a lot of them, with adherence and they either come in or they fall off, and then they come in only when they have a problem and requires, amputation or something. But even doing the right things of getting patients in, stratified, we manage their toenails, their calluses, their deformities, appropriate shoes and inserts. Folks can still get into trouble.
Yeah. I'm going to dip a little bit into another place that you show up during the week, and that's the wound center. Because we're kind of into the wound center a little bit, what we're talking about here. Can you just briefly tell us how the hyperbaric oxygen where that fits in if people get into trouble and have an issue with a diabetic ulcer on their foot?
Sure. Again, this goes back to, I'm very proud of CGH and where I work. And I've been here going on 13 years now. And when I looked at the community as trying to figure out where I was going to go and where's Sterling, Illinois, and what's this all about, I saw that they had a wound center and they had 2 hyperbaric oxygen chambers. And I was like, what? For a community that size? Like, this is just crazy. And it's great for somebody such as myself who's trained in all these capacities, because I can practice to my fullest extent, which is really important to me. The wound center, again, giving a shout out to them. I know it may be a little early for shout outs, but as being a center of distinction for a long time, for 6-7 years. I mean, we do good work over there. And
Yep.
Hyperbaric oxygen in particular, I guess, getting back to the answer to your question. So in my world, again, I treat everything below the knee in terms of wounds. There are times where patients will qualify. You meet specific criteria to go into what's called the hyperbaric oxygen chamber. What that is a chamber whereby we're able to deliver external oxygen, compressed, similar to what you would get in terms of scuba diving, for example. So we take you down to, we compress it at 2 atmospheres of pressure, which then drives that external oxygen into your tissues. And as with anything in medicine, there's data out there to support and data not to support. But in my world, in my practice, I think it's a great adjuvant, meaning additive modality to try and help people heal. It's not the end all be all. Sometimes people get sent to the wound center and they say, oh my goodness, we're going to get hyperbaric oxygen and it's going to save my leg. And this is the only thing that I've been missing in my care. That's just not true. It is an additive benefit. But it is a service that we offer here. We have 2 chambers. And so um, certainly we need, I mean, not we need, we have patients in, it's just a matter of having patients come and utilize that service.
Sure,
It
sure.
is a great service.
Yeah, for sure. Okay. Something I've always wondered, and I should know this, but I don't, is like blisters. So someone gets a blister, and some people will say, well, cut them open, open them there. And other people will say, leave them be.
Yeah.
What would you say, like the best way for someone who gets a painful blister some way or another? What's the best way to treat that?
Boy, that's a great question. There's no right answer. I
Oh,
wish
good.
there,
I'm okay then, because I've
yeah.
always been like, ah.
I just it's variance on the situation, right? So it depends on the patient, and I hate to always say that it depends on the patient. And you got to kind of develop a plan of care for that particular issue for that patient. Um, so goes anything in medicine, really. Um, the general rule of thumb, at least it's how they taught us in school, right? Was that if it's a clear blister, meaning it's filled with serous type fluid, and you can tell that's an absolute just blister, for example, from running a marathon,
Yeah.
that's something kind of expected, that you can leave those intact, and that the body will resorb that serous fluid. It is there's no signs of infection.
Hmm.
It's kind of the body's natural band-aid, if you will, and that it'll resolve on its own. Um, and then if it's bloody, then you should probably explore that through aspiration, debridement, or deroofing it, and exploring that to find out what's the underlying source, because there's probably deeper tissue injury. And then, of course, if there's purulence or you're worried about an abscess or an infection, then it's similar. You have to explore that.
Yeah. If it starts smelling bad, they need to see you.
Yeah. Yeah.
Yeah. Okay. Good. We have tons of conditions we can talk about today, but the last one I wanted to talk about is a pretty common one for folks, and that's called plantar fasciitis. So, if you would, just what is it, what causes it, and what are some tips that you have for folks who have that in terms of trying to get better?
Sure. Well, again, going back to foot pain is not normal, right? Should be evaluated. Heel pain is probably one of the major drivers of new patients into our service. And not all heel pain is created equal. Oftentimes, patients will come in and they think they have heel pain associated with plantar fasciitis, and you find that it's something different, right? So, even though it's relatively common, and you just can't take it for granted, and it does need to be evaluated and confirmed that it is indeed plantar fasciitis. The plantar fascia is a structure on the bottom of the foot. It kind of acts like a roofing truss. And so if your foot is arched like this, and I can't really get my finger, there we go. Yeah. So the fascia attaches to the back of the heel bone like this, and then fans out to the ball of the foot and kind of forms an arch. And it's a support structure for your arch in particular. It's a fascia in the body is not stretchy like a ligament. So we have fascia that holds our guts together and our belly and other areas of the body as well. So it's not stretchy. And so the design of the foot is it's rather dynamic. It's attached to two fixed points. As your foot flattens out through stance, it gets longer. And so being that it's attached to two fixed points, it's not stretchy. The only way that it actually gets longer is through a series of micro tears. And these micro tears within the fascia can then lead to overuse and subsequent inflammation, right? So anytime you have tearing in the body, whether it be muscle, ligament, tendon, whatever, is going to cause some element of inflammation. And that inflammation that inflammation drives our pain, right? So it's uncomfortable. Commonly, we'll hear that patients describe pain on first step. And that's a kind of a hallmark question that we ask. How's it feel when you first get out of bed in the morning? And the patient, oh my God, it's awful. It drives me to my knees. And then I kind of get going. It feels a little bit better. And then I think it's better. And at the end of the day, it's just on fire. So that pain on first step, or it's called post-static dyskinesia. and that's kind of a hallmark of plantar fasciitis. But it's an overuse injury of the fascia, and our job to try and get that inflammation reduced to make you feel better. We can do that through, again, various series of different modalities. And then fundamentally understanding the mechanics of the foot in terms of what can we do to try and prevent that from happening so much to then get the patients better long term. About 98% of reported plantar fasciitis can be treated conservatively. There is a small subset that kind of go on to need of more aggressive treatment, which may require surgeries. And again, those can vary from minimally invasive, kind of non-invasive surgical techniques, minimally invasive, to then an open type repair.
Okay. Yeah, good. Well, hey, thank you so much, Dr. Riley, for taking the time to chat with me today. As always, really good information. And oh yeah, so this is one of the comments. I'll let you read that.
Wouldn't be able to. Oh, well, good. Biking every day. That's good. That's well, Dr. Bird, you would appreciate that as well. You're a cyclist, so you like to ride a bike. So anything we can do to keep people on the bike is good.
Yeah, that's right.
Fixed a torn tendon in my ankle foot. Did a wonderful job. Very pleased. PT is very. Thank you, Jackie. Yes, PT is very important, as you know.
Yeah, good. Well, hey, Dr. Riley, thank you again, as always, for taking the time to join me on Facebook Live. And
yeah, glad to do it. Thanks for having me.
Yeah, take care. Okay, great. Thank you, Dr. Riley. All right, so here's the rest of the thing I want to talk some information about. Oh, thanks, Donna. I want to talk some information about the pandemic and COVID. A little bit more than detail than usual. Just an update here. So this BA5 and BA4 variant are now about 70% of what we're seeing, which is basically causing the number of cases to stay about the same and not really taper down, because we've gone from one variant to the next. Fortunately, right now at least, even though that's still ongoing, the number of patients that we have in the hospital still isn't anywhere near. We tend to have patients in the hospital still with COVID, but the number is nowhere near what it was during some previous surges. So far, at least, I'm very thankful for that. I did see something this week that the numbers would say that from March of 2020 to October of 2021, COVID was the third leading cause of death in the U.S. It was 1 in 8 deaths were related to COVID. That's about 350,000 people. One other thing I was reading that I just want to let folks be aware of, first of all, that I just saw this before I got on. They were talking about what kind of symptoms are more typical for these current variants. And they basically say that think in terms of your vocal cords to the tip of your nose in terms of symptoms. So what you're not going to see quite as much of, it's going to be more cold symptoms and sore throat, fatigue, muscle aches. But what you're not going to see quite as much of with these variants are shortness of breath and also loss of taste and smell. Not that they can't happen, but just not as often. So what that goes along with is to say that if you have, you think you have I've heard this a lot of times. I thought I just had allergy symptoms, or I thought I just had a very mild cold. I would test, and because there's a good chance it could be COVID rather than just allergies or a cold. And the other thing I would say is if you do a home test, an antigen home test, if it's negative, I wouldn't just say I'm good. I was reading a study where it tends to, in terms of being accurate, it's more accurate if you do follow up another test in a day and at least one other test in a day or so. It tends to peak in terms of the likelihood of being positive about 4 days after the onset of symptoms. So with those home tests, test more than once if you're negative. If you're positive, I think you can count on that being accurate. But if it's negative, I wouldn't just say you're in the clear. The other thing I saw recently, and I don't say these things for anyone to live in fear or to not go about living your life, but it is becoming apparent that reinfection, particularly within 6 months of your first infection, is not good in terms of you can actually get sicker. You'd think that you'd have a little bit of immunity built up, and so you'd be less sick. But at least this one study I was reading, that your risk of dying is twice as much and hospitalization is 3 times as much if you get sick with, again, particularly within that first 6-month window. So once again, just wanted folks to be aware, be smart. If you're out and about in a big crowded place, if you're immunocompromised in particular, throw something on, throw like a KN95, unless you absolutely have to take that off. If your immune system's okay, I get it. You have to go about things, but just be aware of that. So the other thing we've talked about this quite a bit, but it's been a while since I've mentioned this, but I thought it was worth talking about. There's vaccines and whether or not they're good or not, and all the risks with a vaccine. Yeah, this was a piece of data that just once again reinforces to me that you're way better off to have been vaccinated. And I get that the most recent variants don't match as well to the vaccines that we currently have. But let's just say this: from December 20th through December of 2020 to September of 21, that's when the vaccines first came out. They've done the models on that. The epidemiologists have done the models. That prevented 27 million infections, 1.6 million hospitalizations, and 235,000 deaths because of vaccinations. So I know, to me, it's just hey, these are good things. They're good things to have on board, and the risk to them, even though they're not without risk, no way, no how, those risks are higher than the rewards that folks that were vaccinated received. So I just wanted to mention that. I don't typically get on that bandwagon, but saw that data this week and thought it was worth mentioning. Okay, shout out time. We have a lot of shout outs today. Matt, I'll let you lead our shout out department here. So first of all, I want to congratulate Dr. Rita Hart. Just retired last week. And it's been great. Dr. Hart's has been a pediatrician here at CGH, did a wonderful job. It was great to have her, and I wish her nothing but the best in retirement. We have more, though. Alice Fetter. She has been the director of our cardiac services and ICU here at the hospital for a long time, has done a great job. She recently retired, and I want to wish her the best as well. So Alice, shout out to Alice. Cheryl Baker. Cheryl has been the director of our lab for several years. And in particular, she's been the director of the lab during this pandemic, which I'm going to tell you was a job to try to manage with all the all the things that have happened in that world since the pandemic hit. So Cheryl, well-deserved retirement for you, and thank you for all your work that you have done here at CGH as well. And I want to congratulate. We talked about our rehab department today on our call with Dr. Riley, and Jennifer Adamson and Allison Yem. Jenny and Allie is how most of us in the rehab world know them. Congratulations to them. They've added to what they already had in their tool chest to take care of patients. Jenny got her board certification as an orthopedic clinical specialist, and Allie got her board certification as a neurological clinical specialist. So I just, congratulations to them, and they are not alone in having they have these board certified clinical specialists at our rehab department. I'm just going to tell you, and I know I'm biased, but we have a really, really good rehab department, and not every rehab department is cut out the same. So yeah, I agree with you, Kathy. And we have great receptionists at our rehab department, Kathy being one of them. So anyhow, I just wanted to highlight them and talk about the work that they do and the work that we do in our rehab department. What else do we have? Talia. I've known Talia for a long time, and Talia is the employee of the month for the month of July. So congratulations to Talia. Talia works up on our medical floor and does a great job, and well-deserved, Talia. Okay, it was a big shout out month, and yeah, I agree with you, Anna. Yeah, it was a big shout out month, and I'm so glad we get to do those to highlight folks that have continued to do and have done and have retired and or are continuing to do great work here at CGH. Just so many great people here at CGH, and I can't thank them enough for the work they do on behalf of all of those who are watching that are in the community. Okay, so next time we do this, it's going to be July 21st, and I'm going to have Dr. Hatum with us. Dr. Hatum actually works for NICTIC, which is it's our radiation oncology area, and it's not, I say ours, actually it's a joint venture owned by both KSB and CGH. But Dr. Hatum is a radiation oncologist, and there's some really interesting things that center has begun doing here that I thought, I ran into him and talked with him a month or so ago, and I'm like, we got to get you on here and talk about some of this stuff. So looking forward to having him here on July 21st as part of our Growing Healthy series through the foundation to talk about what's new in radiation oncology. Hey, I've taken a little longer than usual, and I thank for those of you who've hung with me, sticking with me throughout this broadcast. I thank you for taking the time to listen, and if you found it helpful, please feel to share it with others. And thank you for watching. And until next time, take care. Have a great couple of weeks. This is Bill Bird, Chief Medical Officer at CGH Medical Center, signing off.